Morning everyone. My name is Nisa Kondil and I'm currently a second year Masters of Nursing student at Western Sydney University. And today I'll be presenting a case study about Mr. Birmingham, a 58-year-old man who presented to emergency department with acute respiratory distress. In this presentation, I will discuss four key areas such as high priority clinical manifestations, the pathophysiological links, and how multiple conditions contributed to his symptoms and a management plan. Let's begin with high priority clinical manifestations that trigger the MET call using the primary survey, which is through A to Z assessment. Starting with airway, his airway is patent and he is only able to speak in single words and is tripoding. These signs indicate extreme respiratory effort and suggest that he is at risk of respiratory failure. Under breathing, his respiratory rate is significantly high at 38 breaths per minute, and his oxygen saturation is 77%, which is low on room air. He has bilateral high-pitched wheeze and reduced air entry in the right lower lobe, indicating severe respiratory distress and impaired gas exchange. In the circulation, his heart rate is 122 beats per minute, which suggests tachycardia, and he is flushed in the face and neck, likely due to systemic inflammation or increased work of breathing, as well as dry mucous membranes suggest dehydration, and a soft murmur is noted over the mitral area. For disability, his GCS is 14 by 15. He is disorientated to time, place, and person, which is most likely caused by cerebral hypoxia due to lack of oxygen levels, and his pupils are equal and reactive to light, POL 3 mm. Additionally, under exposure, he has a high temperature of 39.2 degrees Celsius, unable to walk without assistance, and could not lie flat, which reflects physical exhaustion and severe clinical deterioration. These clinical signs clearly meet medical criteria, including severe hypoxia, altered consciousness, and abnormal vital signs, which require prompt recognition and escalation, which are essential to prevent further deterioration and initiate life saving interventions in this critically unwell patient. Now, the pathophysiological link between these symptoms and his medical conditions. Mr. Birmingham, who has late onset asthma, a form of asthma that develops in adulthood and often presents more severely, it is characterized by ongoing chronic inflammation of the airways, bronchial hyperresponsiveness, and episode of reversible bronchoconstriction. During exacerbation, swelling of the airway lining, muscle tightening, and mucus production result in reduced airflow and difficulty breathing. His low SpO2 level 77% is likely due to ventilation perfusion mismatch. When the airways are inflamed and narrowed, oxygen delivery to the alveoli is impaired, leading to inadequate gas exchange, where the body attempts to compensate by increasing the breathing rate, which accounts for his rapid respiration. Moreover, confusion and disorientation are likely caused due to hypoxia, which occurs when the brain does not receive enough oxygen. Furthermore, in severe respiratory failure or respiratory distress, this lack of oxygen causes hypoxic encephalopathy, often presenting as restlessness, confusion, or a decreased level of consciousness. Furthermore, his culture tested positive for Pasteurella multisida, a bacterial organism known to cause lower respiratory tract infections. This bacterium is caused by or transmitted by animal bites or scratches such as dogs and cats, and can lead to serious lung infections, particularly in individuals with immunocompromised. For instance, the lab result revealed a C-reactive protein CRP level of 19 mg per liter systemic inflammation, which is higher than normal range, indicating significant systemic inflammation. Additionally, his echocardiogram shows elevated pressure in the pulmonary artery, indicating the presence of pulmonary hypertension, which can result from chronic hypoxia and place strain on the right ventricle, leading to symptoms like cold extremities. Now I will explain how Mr. Birmingham's coexisting conditions contributed to his clinical presentation. Mr. Birmingham's clinical presentation is a result of the complex interaction between his pre-existing medical conditions and the acute respiratory infection which is he currently experiencing. His late onset asthma is a chronic inflammatory airway disorder that causes reversible bronchoconstriction, excessive mucus secretion, and airway narrowing, which causes severely impaired airflow and accounts his symptoms such as wheezing, high respiratory rate, and use of accessory muscles during respiration. His long-term use of corticosteroids, prednisolone 30 mg per day, cause immunosuppression and increased susceptibility to infections such as Pasteurella multisida, which can further trigger the lung infection and an acute exacerbation. In addition, his heavy smoking 50-pack year likely cause chronic airflow obstruction and reduce lung function, limiting his ability to manage during the time of respiratory distress. Moreover, his echocardiogram results reveal pulmonary elevated pressure in the pulmonary artery, suggesting chronic hypoxia and increased strain on the right side of the heart, which contributes in impaired gas delivery to the body, which explains his cold extremities and poor perfusion. Furthermore, his altered consciousness, GCS 14 by 15, and disorientation are likely due to elevated carbon dioxide levels, PaCO2 120 mmSg, and reduced oxygen PaO2 49 mmSg, which can lead to respiratory acidosis, PS 7.16, and cerebral hypoxia, as seen in the case of Mr. Birmingham. His electrolyte imbalances, including low sodium and potassium levels, may further contribute to neurological symptoms and muscle weakness, impacting bronchial smooth muscle contraction, potentially increase airway inflammation, and alter fluid regulation in the lungs. Therefore, combine all these uh, all these effects of asthma, respiratory infection, weak immunity from steroid, lung damage due to excessive smoking, and respiratory failure result places him in a critical clinical condition that require immediate medical attention and advanced medical intervention. So the final stage or final section covers the high priority interventions, which are oxygen therapy, continuous patient monitoring, pharmacological management, and ongoing long-term treatment. Firstly, oxygen therapy. For Mr. Birmingham, who is experiencing severe hypoxemia with an SpO2 of 77 on room air, immediate initiation of oxygen therapy is essential. In patients with severe asthma and respiratory distress, oxygen helps to correct its deficit in the bloodstream, thereby preventing tissue hypoxia and organ failure. High flow oxygen should be administered immediately without delay, aiming to achieve target saturations between 94 to 98 as recommended in acute asthma guidelines. If pulse oximetry is not available at the time, start oxygen therapy without delay and monitor as soon as possible or as soon as it become accessible. In situation where oxygen therapy alone does not sufficiently improve the oxygenation, um, as in Mr. Birmingham case, with persistent hypoxia, often require escalation to the use of positive pressure ventilation methods such as continuous airway pressure CPAP or bilevel positive airway pressure BiPAP devices to maintain airway patency, reduce the work of breathing, and enhance gas exchange by forcing into the lungs during inhalation and exhalation. Therefore, early and appropriate oxygen support plays a critical role in stabilizing Mr. Birmingham's respiratory status and improving clinical outcomes. Similarly, continuous bedside monitoring of lung functions such as peak expiratory flow or forced expiratory volume is essential in Mr. Birmingham case as it helps assess asthma severity and treatment response, as well as monitoring vital signs such as heart rate, respiratory rate, blood pressure, SpO2, ABGs, and fluid balance, along with neurological signs such as drowsiness, confusion, which is particularly important because it allows health care staff to detect deterioration early in time, evaluate how well interventions are working, and make rapid adjustments to prevent respiratory failure. Furthermore, pharmacological management in case of Mr. Birmingham, who is experiencing acute severe asthma with hypoxemic respiratory failure, early administration of high dose oxygen driven nebulized beta 2 agonist is a critical first line treatment which helps rapidly relax the bronchial smooth muscles, relieve bronchospasms, and improve airflow. Systemic corticosteroids such as intravenous hydrocortisone should be provided, especially as oral administration is not feasible, as these are used to reduce inflammation, decrease decrease mucus production, and prevent further exacerbation. If there is a poor response to inhaled bronchodilators and the patient peak expiratory flow is less than 50% of the predicted value, a single use of IV dose of magnesium sulfate 1.2 to 2 gram over 20 minutes should be considered, which is known to act as a bronchodilator by relaxing the airway muscles and improving airflow in cases of severe asthma, as well as if his symptoms persist despite nebulized therapy and IV magnesium. Further escalation to intravenous beta 2 agonist or aminophylline may require, which serve as secondary bronchodilators and are typically reserved for patients who remain in distress after first line interventions. So uh, these therapies must be initiated under close supervision by a critical care team, as Mr. Birmingham's condition places him at risk of respiratory failure and further deterioration. Ongoing and long-term care, making aware about asthma management plan to patient, encouraging to change lifestyle activities such as healthy diets and smoking cessations, arranging follow-up and offering psychosocial support as frequent exacerbation and ICU admission can affect mental well-being is very important. In conclusion, Mr. Birmingham's acute respiratory crisis resulted from the combination of asthma, corticosteroid use, bacterial infection, and strain on the right side of the heart. Require Metcol, which plays a vital role in preventing further respiratory failure and improving his medical or clinical condition properly. These are the references I use for throughout my presentation. Thank you so much for your time. I really appreciate it. Thank you so much.